Good evening, everyone, and we welcome as we observe the World Thalassemia Day today. So, thalassemia is a major health concern in India. We all know that. In fact, India has the largest number of thalassemia patients in the whole of world, specifically beta thalassemia. So, that treatment, like the blood transfusions and other treatment, does put a lot of pressure on our healthcare system. The government is trying to help with their initiatives under the National Health Mission. It is trying to, facilitate their treatment. But I believe as doctors, I think our efforts should be focused more on preventing the birth of thalassemia major children. And this can be achieved by proper genetic testing and a good genetic counseling. With keeping this in mind, we have two brilliant geneticists today who are going to take us through our scientific program. Dr. Ratnapuri is the director of Gangaram Hospital Genetic Department. She has been the past president of SFM, and she's a world-renowned authority in the field of genetics. And I'm looking forward to a more insightful lecture on what is recommended and what is new in this field. And this will be followed by Dr. Dipanjana Datta's panel, where she will take us through a case-based approach on hemoglobinopathies. Dr. Dipanjana Datta is another brilliant geneticist we look forward to. She has been an active member of the SFM, and we really look forward to both of these scientific programs as the evening progresses. So over to you, Dr. Ratnapuri. We are really looking forward to this lecture. You're muted, ma'am.
Yeah. Is my screen seen?
Yes, ma'am.
Okay. Good evening, everyone, and thank you so much for this meeting and for this talk, which I'm going to talk on what is recommended and what is new on the occasion of this World Thalassemia Day. And so we do know that thalassemia and hemoglobinopathies are hemolytic anemias due to premature destruction of the red blood cells. And essentially, there is a disorder in the structure or the synthesis of hemoglobin. And it's one of the most common genetic disorders worldwide. So the hemoglobinopathies include alpha and beta thalassemia and abnormal variant hemoglobins, like we see on reports of sickle cell, hemoglobin C, hemoglobin Lepore, hemoglobin D Punjab and Iran, and hemoglobin E. Thalassemia major or intermediate are essentially phenotypes. And I'm not going to talk about them because it's going to be addressed in the panel discussion. And Dr. V.K. Khanna, who's actually really an expert on management of patients with beta thalassemia, is here. So what I'm actually wanting to show is that the burden in India is huge. It is not uniform. There are parts of India where we have hemoglobin E that is more common, which is really the eastern sector of our country, the central region where hemoglobin S is common. And we have these communities that you see up on the screen where the beta globin gene mutations are common. And there are various reasons that have been postulated as to why the frequency of hemoglobin disorders is high. And that is one of the reasons, because of consanguinity, the natural selection, the high incidence of Plasmodium falciparum, as well as movements, the genetic drift, and founder mutations. Because of the endogamy that is there in our country, we have a high burden. And so there is a WHO position that there is a right of each individual to health, and therefore we need good care of our patients with beta thalassemia. And in addition to that, every control program should be an intrinsic part of the national healthcare systems, where we have prevention, management, and social care as a part of how we look after our patients with these genetic disorders. And there is this global review of 2027 of the Thalassemia International Federation. And what I've highlighted here, so it's global, but this is the part from South Asia and Southeast Asia. And I have highlighted the burden in India, and you can see that the burden is high, not only of beta thalassemia, but of sickle cell disease at the lower part of this table, as well as hemoglobin E carriers. And this recent paper from the Lancet, where again they have discussed what the burden is and how do you calculate the burden. It's the lost years because of mortality and the lost healthy years because of the morbidity. And that's how this burden is measured. And we can see the burden across and the various reasons for the burden. But what is encouraging in this paper is that they have shown that there has been a downward trend in the prevalence from 1990 to 2021. But of course, still the burden on its own remains very high. So we know that thalassemia is an autosomal recessive disorder. Both partners are carriers, and there is a 25% risk of disease in every pregnancy. And if both partners are carriers, genetic counseling is very important. They have to be given the various options for testing, or they may choose not to test. It's essentially their choice. But this has to be offered in every pregnancy because you can see how I've drawn the variant alleles. And this distribution can happen in every pregnancy, and the risk of 25% affected versus 75% not affected is there for each conception. And this is the same thing that's represented in a diagrammatic manner. And we also know that if one partner is a carrier and the other is not, there is no risk of disease for the baby. There can be a 50% chance of carriers. There are very, very rare situations where there can be a new mutation that is not inherited and cause disease, but it is very rare. So therefore, when we counsel, we don't write there is no risk of disease. We say that the thalassemia major is less likely to occur and prenatal diagnosis is not indicated because of a inherited gene causing the mutation, causing the disease in the offspring. Now, we are all very familiar with this, that in the embryonic period, we have the embryonic hemoglobin. After about 8 to 10 weeks of gestation, it's the fetal hemoglobin that comes up. And after birth, the fetal hemoglobin goes down and the beta globin gene, hemoglobin becomes the predominant hemoglobin. And so in the structure of the hemoglobin, we have two alpha chains and we have two globin chains, beta globin chains, two alpha globin, two beta globin with a heme that binds onto the iron in between. And this is the perfect interaction and everything goes well. The gene cluster, you can see that there is a cluster of the beta globin gene here, which is beta delta gamma, the gamma with the alpha making the fetal hemoglobin, the delta with the alpha making hemoglobin A2, and the beta with the alpha making hemoglobin A. This is fetal hemoglobin, goes down in adult life after birth, and the predominant adult hemoglobin is hemoglobin A with a small amount of hemoglobin A2. And the pathophysiology is when there is an alpha-beta mismatch. Remember, I showed you two alpha with two beta. Whenever there is this mismatch and the globin chains get disturbed, there is precipitation in the red blood cell precursors, hemolysis. The body tries to compensate for it. So there is bone marrow hyperplasia and extramedullary hematopoiesis. A lot is known about the beta thalassemia mutations in India. We have some mutations that are very severe and they do not allow the gene to form any protein. And this results in the severe transfusion-dependent thalassemia major. There are other mutations that are beta plus and beta plus plus, which means that some amount of the protein from the hemoglobin gene can be synthesized, and therefore it can result in moderate or a very mild phenotype of the disease. And when I said that a lot is known, we actually have the mutations well mapped out in different parts of our country. There are lots of publications with the maximum work having been done here. And you can see that we have about 10 mutations which constitute to about 90 to 95%, and 5 which constitute about 80 to 85% of the disease burden. And so understanding this background, every laboratory will set up their own system to look at these mutations in patients with beta thalassemia. Now, this is what I talked to you about. We have some phenotypes which will manifest. They could be mild, they could be major. It could be just the 2 beta globin gene alleles, or it could be various hemoglobin variants like delta beta, lepore, hemoglobin E, hemoglobin S. Whilst this is a lot of variants that even if they come together, they will not cause disease. And therefore, in these situations, prenatal diagnosis is not indicated. I'm not going to read through them. They are available in most books, but it's important to have this to know that we are not going to do prenatal here. What is the need for molecular testing? Because thalassemia can be diagnosed by HPLC, as well as carriers are diagnosed by HPLC. So it gives us an idea about the phenotype and the severity of the disease. There are various drugs based on the polymorphisms in different genes that you can give the medicine to decrease the severity of the disease phenotype. And of course, it is imperative for prenatal diagnosis. You have to identify the mutations either in the first affected child, or if it's a primi gravida, in both partners before fetal testing is done. Coming to alpha thalassemia, it's a little more complex than beta thalassemia, because in every chromosome there are 2 alpha genes. So we have a total of 4 alpha genes, and they come together in different combinations to cause 4 phenotypes. The most severe is the hemoglobin Bart's hydrops fetalis. The milder is the hemoglobin H disease. And then we have the carrier phenotypes where there is no phenotype. So we are aware that we have a national sickle cell anemia elimination mission. And this notes that this is a huge public health problem, and we need to eliminate sickle cell disease by 2047. And the government of India, on the website in the Ministry of Health and Family Welfare, has all this material that is available, as well as a dashboard as to how many are being screened, how many prenatals is being done, etc., to address this issue. So a little bit new about beta thalassemia gene therapy. I'm sorry, this is not intrauterine. There is no intrauterine gene therapy. Now, we know that in sickle cell disease, there is sickling and a vascular occlusion, as you can see here. This is what happens. And in beta thalassemia, there is lifelong transfusion. Hematopoietic stem cell transplant is the definitive treatment for patients, but there are so many buts here, because they can be graft versus host disease. 25 to 30% may not have a suitable donor, and therefore is the role of this gene modification therapy. The first proof of concept came for sickle cell disease, published in 2017 in NEJM, where in one boy, they took out the hematopoietic stem cells from the bone marrow ex vivo. So outside the body, they introduced a functional gene, which was an anti-sickling phenotype of the beta globin gene, put it inside a virus which was stripped of all its infectivity, and introduced this back into the bone marrow of that boy. And 15 months after the transplant, he had no vaso-occlusive events. He did not require transfusion. You can see that there was repopulation of his hematopoietic lineage by the gene therapy, which is this blue line. And you can see that this hemoglobin, which is this beta A globin, the new hemoglobin that went in, had populated his bone marrow. And so after this, once the safety profile was seen in this, and they saw that the gene that has been introduced, the new gene, is not going somewhere else in the nucleus and attacking another part and causing side effects, something we refer to as insertional mutagenesis. There were additional people who went on to trial, and this gene therapy was approved by the FDA. And so the other gene therapy is the Zynteglo, which is again ex vivo. That means you bring the cells out of the body, put in this gene, and this was for beta thalassemia. So that was for sickle cell disease. It's the same thing, but they are given two different names. And this again was tried on 23 patients, and these became transfusion independent, majority of them, which is something which is really unheard of in thalassemia. And to understand gene editing, so this was the CRISPR-Cas9, which has a guide that guides you to the point. It has a scissor that cuts it and corrects whatever is not okay. And this becomes the corrected segment. So this is by this CRISPR-Cas9 technology. And this was something which was done for sickle cell disease and beta thalassemia, because the researchers realized that when there is a high level of hemoglobin F, the sickling or the disease phenotype of beta thalassemia is prevented, or it is a milder phenotype. So they wanted to retain hemoglobin F high levels. And so they went down to understand what converts the hemoglobin F in the fetal life to hemoglobin A after birth. And there is this gene, which is the BCL11A, which is a repressor of fetal hemoglobin, and therefore the adult hemoglobin comes into play. And they thought that if they knock off this gene by this scissor, which is the CRISPR-Cas9, there would be a situation where the hemoglobin F would be in high levels, and therefore, kind of like decrease the phenotype of these patients. So this was really the world's first CRISPR-Cas9 gene editing. It was tried on 2 patients of beta thalassemia and SCD, and they became 89% transfusion independence. Of course, there are costs, and because they go into the bone marrow, there's myeloablation. There is a chance that the gene will go and attack another part of the nucleus and cause problems. These are the problems that we have with all gene therapies. But suffice to say, we are in a situation now where we have 2 kinds of products for the treatment of sickle cell disease as well as transfusion-dependent thalassemia. One that is cell-based and does not involve a virus, which is what I just showed you, to repress the BCL11A. And the second, which is the lentivirus-based therapy, which introduces this new gene into the cell body. Now, these things cost 18 crores, 19 crores. And because we have the same for other genetic disorders, and you might as well not have the therapy for our patients. But actually, there's a silver lining, because we have lots of people now and researchers, basic scientists in our country who are working on this. So they have to develop, because all those things are patented. This group from IGIB has developed the ingenious CRISPR technology, which is FN-Cas9. It is derived from a bacteria. And so now once this is available, there are many, many people who are working on different aspects using this CRISPR-Cas9 to edit and correct the genes. And so with those advances, which are most exciting, I think I would finish my talk here and look forward to the panel discussion which is going to discuss even further beyond this.
Thank you, ma'am. Thank you for such an insightful lecture. Should we take the questions if there are in the later, maybe?
We'll take the questions later, so we'll request Dr. Dipanjana to start the panel for us.
Yeah, sure.
Dr. Dipanjana is a very dynamic, ma'am, thank you for this wonderful lecture. We're really grateful for the insights. Request Dr. Dipanjana, another very dynamic person involved with fetal medicine activities, to kindly take the panel forward. I would request you to introduce our illustrious panelists for today as well. Thank you.
Yes, thank you so much. Thank you, ma'am, for that wonderful lecture. And I will proceed with the panel with the permission of everyone over here. And I just would like to share my slide first, and then we'll go ahead with everything. I hope my slides are visible.
Yes.
So,
Yes, they are.
yes. Thank you so much. So, hello everyone. So, what I will be trying to elucidate is what happens in the clinic, but I haven't taken the common examples. I've taken the examples which are exceptions, so that by this way, we'll also know how to deal with the common ones and also the exceptional ones. So I am the moderator of this panel, and I have a very illustrious panel with me, and I am pretty nervous. So I will just start with Dr. Pranto Chakraborty sir. He's an hematologist. He was ex-professor at our medical college over here. He has worked very closely with the government in setting up the entire screening process, and he currently is also having an NGO and is working very hard regarding the screening and management of thalassemia. Welcome, sir. We have Dr. Kanchan Mukherjee, sir, who's a fetal medicine specialist and has been basically the torchbearer of fetal medicine in Bengal, and is very passionate and active about the entire thalassemia like screening in Bengal as per se, and has been very vocal about it. We have with us Dr. Kaushik Mandal sir, and Kaushik sir is a clinical geneticist. He's from SGPGI, and sir has also been phenomenal in setting up the tests, both the laboratory side and also the clinical side. We have Brigadier Sanjay Singh sir over here. He's a gynecologist. And we also have the very illustrious Dr. V.K. Khanna sir from Gangaram Hospitals, a pediatrician. So as you can understand that we have the who's who for thalassemia, and we couldn't have much better panel over here. So I'll just start with certain basic questions to the panelists and then go ahead and discuss the cases. So, what we understand, as ma'am also repeated that, said before me, that beta thalassemia is something which is very common in India. We have 42 million beta thalassemia carriers, 3 to 4% of the entire population. An estimated 10,000 to 12,000 new cases of thalassemia major has been diagnosed annually, and 25% of the global thalassemia burden lies, and it's basically called the thalassemia capital of the world. If we look at the mutation profile, what we know, as madam also mentioned, that we have certain founder mutations, we have certain common mutations, but as we are screening more, we are getting to know more rare variants. So there are many, much more, and population wise, probably the information is insufficient if we are even looking into the entire part of India. So My first question would be to Brigadier Sanjay Singh, sir. I welcome all the panelists, and I request them to actually please switch on their cameras if possible. And my first question would be to Brigadier Sanjay Singh, sir. When is the ideal time you feel to initiate screening in women who are planning a pregnancy?
Good evening, ma'am. Presently, we are practicing blackout and the can, so I won't be able to switch on my
Okay,
camera. But I'll answer your question.
sure, sir.
So, as has been very nicely brought out by you, that around 40 million of our population is suffering from some form of thalassemia, and around 12,000 thalassemic children are born every year. And the treatment is very expensive, hence, the burden induced on the society is tremendous. In this scenario, the most effective theoretical, at least, approach to reduce the burden onto the society will be to reduce the disease incidence by implementing a carrier screening program which should occur before conception only. That is the direct answer of your question, so that they may be offered genetic counseling. Of course, the PGD is not available everywhere. So the second alternative, which is little practical to my belief, is first trimester screening that will facilitate prenatal diagnosis and selective termination of the pregnancy. But unfortunately, as we know, we don't have any universal screening program in our country, though at AFMC we do it.
Thank you so much, sir, for that very comprehensive answer. And I would now ask Dr. V.K. Khanna, sir, to please take us on that. Sir, do you feel that with the incidents what we have in India, what is the ideal time to screen an infant or the child in case a prenatal diagnosis or a preconception screening has not been done?
See, not we don't recommend regular screening of all infants born with, when out of pregnancy, but as I fully agree, the best results and the best way to time to screen is early in the pregnancy to detect those carriers. But if it has been missed and there is a family history suggestive that the couple might be carriers, then the best time to screen is 6 months, because by that time we know that the hemoglobin stabilize. So A2 will be stable at that time. The chances are that 50% chances, if both the partners are Thal minors, then the 50% chances are there that the child born will be Thal minor, 25% normal and 25 major. So the best time will be, or we can keep monitoring right from the birth. If you feel that spleen has appeared, or at any stage we find that the child is looking pale or irritable, has got feeding problem, then in that case the time is to, because at the time of birth fetal hemoglobin may be around 60 to 80%. But by the time child grows to the age of 3-4 months, it drops to 12%. But if we find at 3 months spleen is palpable, child is pale looking, and we get the HPLC done and fetal hemoglobin is 70% or 80%, then it shows that child might be having a Thal major.
Thank you, sir, again for that beautiful insight. And I will move on with my question. I don't know whether Pranta sir has joined. Sir, are you there? All right. Prantos, sir, Dr. Pranto, are you there?
Yeah, I'm there. I was actually muted. So
Okay,
I can't still switch on my camera because it is disabled. If I
okay.
can, I think now
Sir,
you
you
can.
can.
Yeah. Thank you.
Welcome, sir. So, sir, just I wanted you to just brief us on how is the screening initiated? Like, how do we initiate a screening procedure? Do we first do it? Yeah, sir.
So first of all, we were discussing on our target group, right?
Yeah.
And it was beautifully discussed. Next thing is, where are you screening it, right? In which part of India are you? Because India itself is a continent, right? So if you only believe on MCV and MCH, you will miss the hemoglobin E carriers. When we were doing this Vigyan program almost 20 years back, and we said that when we go by MCV and MCH, even ICMR was not willing to accept that. But when we screened 10,000 people, we showed that unfortunately, hemoglobin E carriers, which are more in Eastern India, including Bengal, Assam, Tripura, parts of Bihar, your MCV and MCH may be normal, but still they may be hemoglobin E carrier. So then what do you add to it? There were certain suggestions like for beta thalassemia carrier, you can do a Nestroff, naked eye, single tube, RBC osmotic fragility test. The problem is you have a significant iron deficient population, which gives false positivity with it. And what do you do with the E carriers? DCPIP, which was standard group, but it was difficult for us to standardize. So if you ask me, even in 2025, should you do it? And I think recent guidelines have come that you are looking at MCV and MCH.
Yes.
Problem is you will miss E carriers. So that is a problem. Now, what are the alternatives? Can you do HPLC in all? Financially, it's a burden. Accessibility is a burden. Can you do molecular screening? Again, accessibility and financial. So I also don't know what is the answer, but when we formulated the guidelines, we said that because of this problem, we will do HPLC irrespective of the MCV and MCH, at least in Bengal.
So basically to include the HBE, so it's as you said, the region is very important. I think even
because 70% of our thalassemics are E beta thalassemia, right?
Yes, sir. Yes, sir. Absolutely. So moving on. So basically, we also need to rule out the sort of the iron deficiency. And as sir said, we have to prioritize the entire clinical history and the place, the ethnicity before we even start a diagnostic procedure. My next question would be to Kanchan sir, Dr. Kanchan Mukherjee sir. Sir, I have been working in the districts a lot, like even in very rural areas. And when we screen and we say that, you know, there in Bengal, there was this thing that pre-marital, you should actually understand whether you are a carrier or not. But right now, there are many people who come up and say that, you know, we have been, there's a huge social discrimination, especially in places which are very, very rural, backward region. When we do camps over there, we do get a lot of complaints and people don't turn up. So, sir, my question to you would be, how do you counsel and manage couples when both partners are found to be carriers? And how would you associate, like address the psychosocial concerns and the stigma associated with being a carrier? So, Kanchan, sir?
Yes, as you rightly pointed out, it is a very sensitive issue, and we have to deliver information with great care because these career people may face isolation, may face rejection, blame, and all those sort of things. So basically, what we do, what we should ideally do is try and normalize the situation as much as possible, saying 1 in 10 in this area is actually a carrier, and I myself can be a carrier unknowingly. I am completely normal, but I can still be a carrier, and I would only know if I get tested. Then with great empathy, then you just need to tell them, give them the genetic risks, and here the visual aids would go a long way. If you tell them that this is your chance, this is what is 25% or 1 in 4 means, and then you say that you have a number of options. Either you go for natural conception, where this is the way you achieve a prenatal diagnosis, and then you decide what to do. Always they should be given the impression that it is their option. They are choosing what they want to do. They might as well say, yes, we want to know, but we do not want to necessarily terminate that pregnancy. So you just give them the open and transparent information. Then if someone says, I am dead against termination, in that case, they can go for PGTs followed by IVF, or even they can go for gamete donation. So you have a huge number of options that they can go by. Now, basically, yeah, that is what I would say. Yeah.
Thank you so much, sir. So I'll go back again to Pranto, sir, because he has worked in the government setup, and these are specific questions regarding the government setup. And if Dr. Khanna also wants to add, I like he might. So, what are the national or state level policies right now which mandate? Is it premarital screening or antenatal thalassemia screening? How can we integrate this with, because it's a public health problem? So, how can we integrate it? And should Ayushman Bharat Health and Wellness Centers have thalassemia screening as a part of it?
Thanks for that question. When we started our thalassemia control program in the state, so we had this thalassemia control units whose mandate was management of the existing patients and screening. The problem with health administration is the moment you do something in isolation and it is not integrated, you do not get help from other quarters, right? So they had a separate budget, they had a separate HPLC, they even had a separate data entry operator and technicians. But the problem was the hospital administration felt that these people are of no use, right? Because obviously the awareness amongst us is also not that great. So any public health program has to be integrated into the healthcare delivery system. You start from awareness, right? So why don't we generate awareness when people are walking into the wellness center? Why we had hum do, hamare do, we had polio. Why can't we have signage on this on the walls of primary health centers, wellness centers, and other things? And then why not, like, we were talking of first trimester pregnancy, and we were discussing today that even the ashas have an incentive to get the first visit in the first trimester.
Yes.
And then you have the Prime Minister Yojana, where every month on a particular date, they all come together. Why don't we integrate this screening? And I learned something very interesting today, and I hope it will be changed, that the Chacha Bacha card, which is filled up by the ashas, it
Yes.
doesn't have a place for mentioning the HPLC report.
No, it doesn't. Yes.
Yeah. So you are thinking it is important, you're thinking that it should be integrated, then you have to make all the documents, all the guidelines, whatever it is, to fall in line with that, right? So first question, yes, it should be in the existing public infrastructure. Otherwise, it will be an orphan. Disease is an orphan disease, and now the program becomes an orphan program. So no isolation. Second is, when you're talking of wellness, this is a prime example of prevention and public health, where you're preventing the birth of a thalassemic. So why shouldn't it be done? Now you might say, okay, do I have funds and all that? That is for you to decide when the carrier rate is above a certain rate. Like I do understand in South India, it is not that high. You can start a priori, but it has to be done at that level. And it's not that you put in HPLCs right now everywhere. You can have your referral and you can have a hub and spoke model. But in short, the answer is yes to both of you.
Okay, sir. Thank you, sir, for a very strong,
I
Khanna.
fully agree with
Khanna, sir.
him.
Khanna, sir.
I
Yes.
just want to say 1 or 2 points. One is that the government cannot make it compulsory, this test,
Yes.
because there are some issues we have already
Yes.
discussed with them. So they strongly recommend that. Even Foxy also recommends in their statement that it is recommended that all antenatal cases should be tested for that. And for screening purpose, as Dr. Pranthal was saying, that Nestroff is out, because this is an observer dependent test. मेरे को लगा है या दूसरे को लगा नहीं है, nobody can say definitely in that. So that test is up. And in Delhi also, if you see, in most of the big hospitals, all antenatal cases are screened. As far as premarital is concerned, I gave a long time back, I gave a slogan that instead of Janam Patri match thalassemia status, then I kept quiet because nobody will marry thalassemia minors.
Yes,
They
sir.
have this thing in mind. And many of you must have read that Dr. Roshan Kola's study. I'll take half a minute. They just screened so many cases. And after, when they had grew in the school, high school level, and after many years, they tried to see and trace them. They could trace 41 cases who got married. Believe me, it is written in the paper that none of them had disclosed at the time of marriage that they are thal minors. So the best time to screen is antenatal. Thank you.
Absolutely, sir. Agreed, sir. And thank you so much for that insight. One small point, I don't want to spend too much time on this slide because we have really good cases coming up. But one small point, I have been trying to work with the ASHA workers and going, home door to door. But we do see there is also a problem with people who don't know about the disease. So awareness among the public is also very low. So I feel that if there, as sir said, like hum do hamare do ya polio ya fir the HIV campaign which we did, thalassemia is basically desperately in need of such a campaign. There are many people even in urban areas who will say I actually don't know what thalassemia is, and that's somewhere which I have approached the government a number of times to initiate a mascot and to start a thalassemia campaign which is very similar to HIV or hum do hamare do, so that that in general the people reaches out, because nobody can say that it's mandatory, but if the people reaches out and says that I want it, then it's in some way the screening happens. So I'll just move on to our case, and our first case is a 27-year-old woman who is referred for genetic counseling. During her first pregnancy, her CBC shows microcytic hypochromic anemia. Her HbA2 is 5.8, and of course, she's a trait. Her husband is completely asymptomatic but has a hemoglobin profile with HbF of 25%, and iron studies are normal, and they don't have consanguinity. So that's our case. And my question first goes to Brigadier Sanjay Singh, sir. So, sir, what is your protocol? In such a case, what do you think? Would you refer it to a fetal medicine? Would you refer it to a geneticist? How would you initiate?
Yes, so the first question is as to how do we suspect that a patient may be having thalassemia. This is relevant for the residents. If at all they are there in the session, they'll be benefited. Maybe that these answers that I'm going to give you will help ASA workers also to take those patients for the screening. So the answer is that firstly, the person may belong to a very high risk population. Like my patients do come from Maharashtra, it's a high risk state. Secondly, the hemoglobin doesn't even increase even if the serum ferritin or iron level is normal or there is microcytic anemia with normal iron levels. Thirdly, she may have delivered a baby who has been detected to have thalassemia, or she has a positive family history or transfusion history. Coming to your question proper, in these suspected cases, we do HPLC and hemoglobin electrophoresis, whatever is available of the lady. If it is positive, the husband is also tested. If the husband too turns out to be positive, we refer the patient to fetal medicine specialist or geneticist.
Okay, so who would you choose, sir, between one fetal medicine first or geneticist first?
I would like to choose geneticist first because if the patient does have trait, I mean, the husband is negative, a gynecologist can manage that case. But
Okay.
if the husband also turns out to be positive, then it's a matter of concern. The geneticist has to say whether the baby who is going to be born will be having, will have the blood dependent type of thalassemia or not.
Okay, thank you so much, sir, for that answer. I like your answer. So we'll move on to Kaushik, sir. And here, what I would like to ask him is, sir, in this scenario, the female is out and out trait. The man has elevated HbF. So how would you go further for the molecular testing? What would you test?
Can you hear me?
Yes, sir.
Okay. So one is a carrier, the other we do not know whether it is hereditary persistent of fetal hemoglobin due to activating mutation in the gamma globin gene, or it is a complete deletion of the beta globin gene along with the delta gene. In fact, hereditary persistent of fetal hemoglobin is divided into two varieties. One is the deletional form, where in the HbF is increased, just like hereditary persistence of fetal hemoglobin due to an activating mutation of the gamma globin gene, and he or she is a carrier. So in such a case, when we do testing, suppose the previous baby had thalassemia, then we are very sure that this person is actually a carrier of a delta beta or a deletion of the whole beta globin gene. So that makes absolutely simple. But if the couple comes like this, where the HbF is increased, we are very jittery and we try to find out whether it is a deletion. So the deletion can be seen by MLP, or what we do is actually a haplotype analysis, seeing all the polymorphism throughout the genome, throughout the HBB gene. HBB gene has 3 exons, and there is a 5' UTR and a 3' UTR regions, that is untranslated region, and we have got various polymorphism, heterozygous polymorphism. So what I do, I don't go for large deletional studies. I see if there are polymorphisms. So if the person has some polymorphisms, heterozygous polymorphism, then it is probably hereditary persistence of fetal hemoglobin due to gamma globin gene mutation. Then we test the gamma globin gene. We see nothing, then we are probably sure no heterozygous peaks. Then we are probably sure that there is a large deletion, and we try to prove sometimes with MLPA, and we go for prenatal testing. So in prenatal testing, what we'll find the mother's mutation in homozygous form if the whole gene is deleted from the father, right? So if one of the couple has a large deletion, in prenatal testing, or the child, affected child, will look like a homozygous of the other mutation, because the other allele is totally deleted. So am I clear or slightly clear?
Yes, I think so. So I'll just summarize what you said because it's difficult. So what we are looking at is when we are looking at the thalassemia, like HBB gene. So it's normally single gene point mutations. It's a very small gene, so we can just do a Sanger. Though we previously could do an ARMS PCR, which was, targeted mutations. There are 23 common mutations where ARMS PCR can also pick up. There are certain limitations for the ARMS PCR. We can do an HBB Sanger sequencing. And as Sir said, when we are looking for larger deletions, sometimes Sanger sequencing is not
So
sufficient.
there is a common deletion, you all know, 619 base pair deletion, for which we do a deletional study. Just
Yes.
doing a PCR. And in fact, for thalassemia, all mutations are in exon 1 and 2. The intron one after exon 1 is very small. So we do a simple, and the common mutation of exon 2 is actually in the proximal part only. So one PCR and one Sanger sequencing
Will
picks
do
up
it.
most of the mutations, and all things which we don't understand, we sequence the exon 3, right?
Yes.
Otherwise we don't, we just do one sequencing and one 619 base pair deletion, and that completes our work for most of them, more than 90% of them.
So, and the hybrid ones where there's a delta beta deletion or a very big deletion, MLPA can serve the role. There are people right now who go for NGS, which I feel is a overkill, but Sir can comment like
No,
NGS.
nothing. No NGS, no ARMS PCR.
Exactly,
No
exactly.
NGS, no ARMS PCR.
Yeah, so that is what even my thought is. We normally what the normal test suggests is either Sanger sequencing, which gives us 98%, but depending on the report, we might need, in this case, like we might need to go for an MLPM. So my next question again comes to Sir. What are the potential implications if the fetus has both, like say the deletion and also the beta thalassemia? So it is basically a double heterozygote, as we can call it. Then what happens?
No, this is not double
So
heterozygous. It
this is
will be a
compound
compound. This is a compound
heterozygous.
heterozygous. So, in fact, the large deletion is a severe variant, and probably the child will have thalassemia major. If we look at the other mutations, whatever common mutations are there, the child will have thalassemia major. Obviously, if the mutations are different, we know there are beta 0 and beta plus mutations. There are milder mutations. So, two milder mutations will cause milder variety. One beta 0 mutation and another milder will cause something like major. So the small and there are other modifier genes, especially the alpha gene, which we know. So it will be a spectrum. But in a family, mostly the first child, if there is intermedia, the second will also have intermedia. The first has major, the second will also have major. So it is a spectrum, but we know that some are very common, like E beta are generally intermediate, they present after 1 year of age, but gradually they become transfusion dependent in many cases.
So, sir, when we screen, even Dr. Ratna ma'am also emphasized that all carriers, like all combination of carriers, say compound heterozygous or double heterozygous, will they need transfusion? And is that information important?
Yes, we have to remember that we cannot just jump like with thalassemia. Like there is various HBD mutations, C mutations, right? So and a D which is D Punjab especially, and beta 0 or beta plus mutation, generally they will have mild anemia only at a very severe condition or in stress. So for them, we will not recommend prenatal testing, or will make the couple understand that prenatal testing is not required for them. So it depends upon the mutation and what we are looking at.
My next question would be to Dr. Pranta, sir. So, sir, many a times when we get a mutation, do you feel there's a strong genotype-phenotype correlation? Can we predict whether this will be a non-transfusion dependent thalassemia or a transfusion dependent thalassemia?
Unfortunately, the answer is no.
Yes.
Because if you look at genotype-phenotype correlation, it has been there for more than 30 years now. Whole genome sequencing studies, vast studies from Thailand, from any National Health Institute and all, there is no. And I have so many families, same set of parents. One is an NTDT, one is a TDT, and the other has not required transfusion anytime. So hopefully they have inherited all the same genes. So this is the biggest problem we have. And what do I tell the parents? What will be the natural history of the baby? And considering that in my state of Bengal, you have 70% as E beta. So if it is E beta coming on, do I know what will be the phenotype? You can look at beta 0, you can look at beta plus, and then you can look at even alpha, but still, unfortunately, till to date, we do not have adequate information. But we can have adequate information. And that's why I always advocate for a patient registry where you have the natural history of thousands of patients and you get some insight into what happens into those. Because other than genetic modifiers, we have recently even published in hemoglobin that there are some HLA conformisms which tell us there is something to do with the spleen itself, the vascular things, which also, modify the phenotype. So it's a complete picture, but right now, unfortunately, we are not in a position to predict that if the child has E beta thalassemia, what would be the natural history. And even as Professor Mandal was saying that, if one child was this in E beta, that also doesn't hold true. If one was NTDT, the next one can still be TDT. And we would be then trying to explain maybe this allosteric modification was there, this was there, but we can't predict.
So my next question would be to Dr. VK Khanna, sir. So, sir, when we see a transfusion-dependent thalassemia and a non-transfusion dependent thalassemia, apart from what we are discussing, what are the other comorbidities that we should also let the patient know? Because when we are counseling, we have to give them a 360 view. So, sir, what would be the other things, other management that we should also discuss with the patients?
Yeah, I feel both these conditions, TDT and NTDT, means thal major and thal intermediate, they are two different entities.
Correct.
Thal majors require regular blood transfusion. Most of their complications, even if they are managed well, are transfusion related because of hemosiderosis, excessive iron in the body, and the ill effects of that iron on different body parts. While in case of thal intermedia or NTDT, we find it is because the complications or morbidities are because of abnormal RBCs or platelets circulating because of defective erythropoiesis present. Then because of the low hemoglobin and chronic anemia. That's why. So in cases of, or because of hemolysis like gallstones. So in cases of major, we find complications because of iron overload and transfusion, may be in the form of reaction or uh, iron overload, of course, is inevitable. And then because of hemocytosis affecting various organs in the body. And in uh, TAL intermedia, it's mainly because of the ineffective or poor erythropoiesis. And that causes more of bone marrow expansion and osteoporosis, and then coagulation problems and thromboembolic complications, pulmonary hypertension, leg ulcers, and all those. And even if they have, excess iron, which is absorbed from the GIT because of
Yes.
low
Low.
hepcidin levels, then it goes to the liver first. In THAL intermediate, we don't find cardiac involvement that common, except pulmonary hypertension. They may have a sort of, we can call cardiac issue. Otherwise, they don't have direct cardiac involvement because of iron overload. They get liver involvement.
So, sir, when management is discussed, even in non-transfusion dependent, we also have to probably discuss all of that when we are discussing the natural history and the prognostics, like to make the patients aware. So, thank you so much for the insight in our first case. So, we move on to our next case. This is case 2, and the female partner is 25 years old. Again, antenatal screening was done. For the male partner also, there's no family histories, but what we have on our screen are on the left-hand side, the female partner, and on the right-hand side, the male partner. What we see over here, I'll just highlight that the female partner, many a times we get reports like this, is borderline. You can see it's a 3.4%. The HbA is 92.5. There's no abnormal peaks. The MCV, the MCH is again 73 and 23.5. The RDW is slightly raised. And in the male partner, you can see the hemoglobin is fine, more or less. The HbA is 96.8. The HbA2, I would highlight, is 2.1. But if we are looking at again, the iron studies are normal, but the female partner shows microcystosis, while the male partner has milder form of microcystosis. So now cytosis. So now my first question would now go to Pranta sir again. How would you explain the clinical significance of the borderline HbA2, which we are seeing in the female, and almost a normal HbA2 in the male, but there is microcystosis in both? So do you think this is abnormal? This is normal? What should we do?
Yeah. So the first important thing which you have already done is you have ruled out iron deficiency, right? So that dictum is there for some time, though all people do not agree. Now the thing is, there are certain mutations which do not increase the A2 or keep them borderline. These have been already known, like capsite and others. In fact, there are case reports of even IVS 1.5 presenting with normal A2 values or borderline A2 values. So the problem is, and then obviously our current short programs which we run on HPLC cannot pick up alpha kinase, right? Again, alpha can also have this microcytosis. But whether we are worried and whether we should do a molecular study is the main question. Now, frankly speaking, in such a case, it is better to do a molecular study on the female partner, because that is where you have, and frankly speaking, if that person is normal, then I would not go in for molecular in the other partner. I think a similar question has also come in the chat box, which we will discuss later. So basically, it is all about what are the risks. Depending on the risk, and if I feel that this microcytosis, so we also look at the RBC count, right? The RBC count is also not commensurate with the hemoglobin. I would definitely go for a molecular diagnosis, especially because of medical legal reasons also. In a public health scenario, even one false negative, and if they have a baby, you can imagine the trauma. They would say, we have done what you have told us. So I would go for that.
Okay, thank you, sir. That's a very, again, comprehensive and very nice answer. And I like when you say that we'll test the female partner and, the male partner can be tested on basis of the female partner, which is something which in our cost-effective system, which is very practical. So my second question would be to Brigadier Sanjay Singh, sir. So it would be, what threshold are we talking about when we are recommending partner testing? Actually, Pranta sir answered this question, but if you would like to sort of, give some insights into it. And again, commenting on the iron therapy, like, sometimes when we see these kinds of borderline reports, would you recommend an iron testing also, like screening also, and would iron therapy be part of your regime? Sir? Hello? Sir, are you there? I think he has some problems with his connection.
Yeah.
So,
Can you hear me, ma'am?
oh, no, you are there. Yes, sir.
Yeah.
Please tell.
Okay. So the first part of the question that I think has already been answered, wherein if the patient does have a borderline report of HPLC, and at the same time, if it is associated with microcytosis, I think that it is a trigger for partner screening. And if both are suspected carriers, then there is a role of prenatal genetic prenatal diagnosis that will be warranted. Now, coming to the second part of the question, see, the both iron deficiency and thalassemia have macrocytic hypochromic anemia. So, MCB, MCH is low. We first need to check for the ferritin level. If the value is less than normal, then iron deficiency is likely. We start oral iron therapy. We delay thalassemia screening until 3 to 4 weeks after iron repletion. But if serum ferritin is normal, as again has been brought out, iron deficiency is unlikely. We proceed immediately with thalassemia screening. Logic is that iron deficiency can mask beta thalassemia trait by suppressing HbA2 levels, leading to false negatives.
Yes, sir. Thank you so much for highlighting that. And I think that's a message that we need to also put out here, that while you are doing a thalassemia screening, please also look into the iron if needed. So my next question would be again to Dr. Kaushik Mandal, sir. So given if both partners, so this kind of a peripheral blood smear, but there is no definitive abnormal peak, would you go for any molecular testing, alpha thalassemia testing? What is the residual risk if we are talking about in India, and is it population specific?
So I have been doing molecular testing for beta thalassemia through sequencing and for last 12 years. And I cry every day when people send 3.4 without looking at the iron studies or looking at the other partner for screening. I found none. I found none in thousands of which I have done for molecular. Yes, Dr. Prantar is correct. There are certain where there may not be increased A2, like capsid mutations, but most of them are milder mutations. Capsid mutations are milder mutations, and we don't miss it just to prove. But there are certain 3' UTR mutations which are not mild, right? But they can also have low A2, and that is where we feel jittery. So I keep on sequencing exon 3 and beyond that to look at the 3' UTR that we are not missing anything. But most of the time, when the other partner is fine, we breathe deep and we leave it like that. Though we do the sequencing and prove that there is no mutation and also the 619 base pair deletion. The difficulty comes when there is a megaloblastic anemia and they come with a high A2 and they want that please find the mutation. And the statement that when both are suspected carriers, prenatal testing is warranted is not correct. When we have proven molecularly that both are carriers, then only we can do prenatal testing. Otherwise, we should not do prenatal testing. We should not touch the fetus if you have not proven both the partners to be
True carriers.
carriers and both the mutations or the mutation in both the partners were detected. before we do prenatal testing.
But sir,
But we
let
often
me tweak the question and say this is coming from a tribal part which is around the Bihar border. Would you not do a testing?
I don't understand that. What is Bihar border?
Pranta sir, will you answer that?
No, so what Dr. Mandal said was very relevant, that based on just a suspicion of a carrier, will you proceed for prenatal diagnosis? And the answer would obviously be no.
No,
So I
I'm
agree.
talking about
Yes,
the
yes.
Yeah.
But a couple comes at 20 weeks of gestation and both of them has A2 of 5.6 or 4.5. I generally will do all together because we
yes.
don't miss
Yeah,
time there.
that is okay. That
No,
is
I'm
done.
not talking
We are
about
talking
that.
of
I
this
am talking
couple.
about
We are talking
molecular
of 6
testing with
people
the
where there is
partners.
microcytosis and borderline need.
Yes.
I am
So we
talking
won't.
about the partners. I'm talking about
Yes.
the partners, and I'm talking whether you will look into the ethnicity if it's a tribal area, because what we understand is that there is a small
There.
strip around the Bengal Bihar border, even the Assam border, where we do get a lot of alpha thalassemia cases. That this is my experience. And we do get a lot of positive in
So
those belts.
alpha
So
thalassemia is ubiquitous. It is there all over the northern part of India and probably other parts of the world. And it is ubiquitous. It is equally present. And when there is microcytosis, you think of alpha thalassemia, alpha carriers. And the risk is HBH disease, which is worrisome. And we all know that alpha has 4 copies, two from alpha 1 and two from alpha 2. And where what we do is here the deletion and deletion duplication studies by MLPA. And very rarely we have to sequence the alpha gene. Alpha gene sequencing is not readily available everywhere. We have to have certain guide for that where we should sequence alpha, or else we generally will do alpha deletion studies. If 3 copies are deleted, HBS disease. If 4 copies are deleted, there is a frank alpha, and most of them will present with hydrops, and we don't worry about that.
case
But once there is,
later. Sir, we have a case later. Let's discuss that in the later
okay.
case. Okay.
Oh, sure, sure.
So, okay, sorry, sir. So, I will go back to Dr. Khanna, sir. When we see such borderline cases and say it's an inconclusive report, and they, probably the molecular studies also have been inconclusive. What, would you say there is any early clinical signs or concerns in the neonate that might prompt, even if the prenatal testing was not definitive?
Not definitely in the newborn period, not in all cases. Where we have high suspicion, then in that case we can go for molecular diagnosis. Otherwise, we keep a high index of suspicion on the child, keep examining him repeatedly, and look for appearance of signs like uh, enlargement of liver and spleen in those cases, and any sign of increased erythropoiesis. And
And sir,
then we
also
want to
growth failure in some cases, or sometimes.
growth failure. See, most of these thalassemics, if you see, they appear normal at birth. By now, earlier when I started working on thalassemia, we used to get these cases around 1 year or after 6 months. Now we started getting these cases early. I
Months,
have
four
got
months.
2-month-old child also
Yes.
who's been proven to be thal major, because one cousin had thalassemia in the family, so they missed the prenatal diagnosis. So they came to me. We found that spleen was slightly enlarged. I said, no, go for HPLC. And then we had slightly high for that age. We found high fetal hemoglobin. So we said, okay, go straight away for molecular diagnosis. And in that case, we proved that that child was thal major.
Okay, so we move on to our third case.
We
So
are getting early nowadays.
thank you so much, sir. So we will just move a bit quicker in all these cases so that we can finish all the cases which we have. So this case 3 is basically a case of rare hemoglobinopathies that we find. So this is a Bengali woman. She's 29 years old and her hemoglobin is 11.4. She's basically asymptomatic. You can see her MCV is 76, MCH is 25.2, but she has an unknown Tygart peak at 34.1%, and her HbA2 is 2.6, HbA is 6.8, HbF is almost normal, and her husband is Gujarati. and he has what HBD window peak. Now, in such cases, like both are sort of rare variants. So my question would be to Brigadier Sanjay Singh, sir, like what would be the role, because you would be the first point of contact when such cases come up. So how would you counsel this patient? Like, you understand this is a rare variant. We don't have much information about these variants, but what would be your first, like, how would you counsel these patients?
Yeah, ma'am. So I think that there are multiple roles of a gynecologist in this scenario. You may correct me if I am wrong. Firstly, we need to inform the patient about the rare hemoglobin variant in simple terms that the patient will understand. Secondly, we need to explain that the variant may have clinical significance, especially if the partner is also a carrier. And in view of this, we need to advise testing the other partner with CBC, hemoglobin electrophoresis, and HbLC. If both are carrier, or if the variant significance is unclear, we need to refer them to a clinical geneticist. And then we need to provide, because ultimately the patient has come for the pregnancy, we need to provide basic counseling on reproduction options like prenatal testing, IVF, and PGT, or using donor gametes if at-risk combinations that has already been discussed in detail in earlier sessions are found. And finally, which appears to me very important, is to act as a coordinator between the couple and the specialist in fetal medicine, geneticist, and hematology.
Thank you so much, sir. So my next question would be to Pranto sir. Sir, if you see these kind of double heterozygotes, if we call them, so what would be their natural history, and how would you see, like, how would you, counsel the parents for the natural history of these
Yeah.
individuals?
So if you ask me, have I seen a hemoglobin tiger ever? No. But even whatever the literature suggests, that it has no specific clustering in India, at least, because it has been identified in certain African American and European populations. They're usually clinically silent in heterozygous state. But if the other one, and you said is a Gujarati, so can that person have hemoglobin D Saurashtra, right? It's not hemoglobin D Punjab. It might be hemoglobin D Saurashtra. And so autosomal codominant, and then you have a compound heterozygous. What is known till now? And the first thing is there is, I always say they never feel guilty to say that I do not know. Because if it has not been reported, there are not enough reports, then how can I predict the natural history of what will happen? So if it's hemoglobin Saurashtra, the Saurashtra, I tell them that they in their compound heterozygous state have a variable phenotype. But if it is combined with either hemoglobin S or beta 0, then they can have a severe phenotype, which is not the case here. So if there is no major published case series, and if I extrapolate, most likely it should not be a major phenotype. But there is a potential for diagnostic confusion on HPLC or electrophoresis due to these abnormal migration patterns. Sometimes they do not even match what the windows say. But unless there is, coexisting alpha or beta mutations, it should not have a severe phenotype, but I cannot say what will happen. And I would refer this case to Dr. Mandal. Let him decide what it has. And then also, if it is like this, if you say that one is hemoglobin tiger and the other is Saurashtra, we do not know. Most probably, it will be a milder phenotype.
So even here we have directed our question to Dr. Mandal, and we have done
Yeah.
exactly what you have said. So, sir, can you please take up this
So
question?
there are some good questions in the chat box. Can you hear me? Huh? So if both are E carrier, whether we do, no, we generally will not tell, because even E homozygous is not a severe disease. And apart from E, all other hemoglobin Ds are in
Combination.
exon 3, right? They are in exon 3, D Punjab, then Saurashtra, they are in exon 3, Tigard, they are all in exon 3, and most of them are benign variants. Most of them are benign variants. and HBD Punjab, which is the common form, along with the beta mutation, will likely to have no phenotypic effect or a very mild effect. We have to tell them the outcome will be very mild or no effect according to vast literature which is available. And these children do not have intellectual disability, whether they will like to go for a prenatal testing. So we'll not ask for a prenatal testing. We'll counsel like that they don't opt for a prenatal testing in such situations. But there are some hemoglobin D which will migrate, but the mutation is actually in exon 1. So doing a molecular testing is very, very important so that we can predict the outcome, not if not perfectly, but according to literature, what is available, we can tell them. So doing a molecular testing is a must.
So in this case also you indirectly answer that we
Absolutely,
for molecule.
absolutely. But this is very, very rare that we find two rare mutations in the
No, but
couple.
sir, we
You
are
must have
finding.
cooked it up.
I no, sir, I didn't. Kushar sir, if Dr. Kushar Gadi sir was here, he would have said that I have
No, no,
found this.
I was just joking, but it is very rare. Even I haven't seen two rare
Yeah, it
like
is
this.
rare. It is definitely rare, but we are, I guess, right now finding cases. So that is also there. So my question, there is also a similar question which is there in the chat box. So my question to Kanchan sir, would you actually consider chordosynthesis or an MCA Doppler if we have these kind of, rare variants, because we are screening more, we are finding more. So would you do that? Like, will that be one way to define, the prognosis?
Yes, if we are suspecting fetal anemia, chordosynthesis may have been historically used, but that is completely out of the window now because we have a non-invasive and quite an effective alternative in the form of MCA Doppler peak systolic velocity. That gives us a sensitivity of about 90 to 100%, and it has a brilliant negative predictive value. That means if the MCA Doppler is normal, peak systolic velocity is normal, the fetus is extremely unlikely to be anemic. So in this case, where I am suspecting fetal anemia, then I would go for serial MCA Doppler studies, even though fetuses are very, very rarely anemic in the first and second trimester because they have plenty of HbF. Yeah, but towards the end of pregnancy, when the switch happens from gamma to beta, then only they start being anemic. Otherwise, before that, it's not.
So one question which is in the chat box, I would actually ask you because I know you are the correct person, is that what if the person comes at 24 weeks and, has both are carriers? Would you do a prenatal diagnosis?
Yes, I think they are in every right in having the diagnosis. And what gets done after the diagnosis is again about
Choice of the.
options and being about what the law allows. But my job is to give them diagnosis, and nobody stops me in giving them the diagnosis at any gestation.
Thank you so much, sir. And I think it's always the free will of the patient, and we all we can do is give them a diagnosis and show them the prognosis. But the decision lies in the realm of the patients. Also, right now the PCPNDT.
Panjana, can I stop you? There is a question in the chat box, and I subscribe to that as well. This hemoglobin tiger sounds quite awful to me. Can Dr. Pranta Chakraborty or Dr. Kaushik Mandal explain what is this tigered peak and all those?
Okay. Dr. Mondal, you can go in for the molecular and then I'll talk about the naturalization.
See, there are Tigard, in fact, is a high affinity hemoglobinopathy where they have good oxygen uh, affinity. So generally, it will not cause any problem. So it is actually the other way around. And you know that even beta globin gene mutations can give erythrocytosis. You know? So there can be high affinity. So Tigard is actually high affinity. I don't know how it came. And about MCRT Doppler, I thought I will tell. In this case, probably it will be very pertinent if you are thinking of HbH disease or alpha thalassemia and not just abnormal hemoglobin. The fetus won't have a fetal anemia in this case. You can't detect by MCA Doppler. You can't detect by MCRT Doppler.
No, I'm just only talking about fetal and detection of fetal
Anemia. Yes, yes,
Then
that
it,
is what. So
then
it
it.
the scenario comes when we are suspecting alpha thalassemia or HBH
Yes.
disease in the
The
fetal,
next case.
but
message you
not
have
for
already.
beta
Yeah.
globin.
Yeah, the message you have already given, Kaushik, is alpha thalassemia should be taken into consideration when we are dealing with cases like in non-immune hydrops. It is
Yeah.
not that rare. That's what I was trying to say.
Yeah, yeah.
Yeah.
Okay. So, Pranta sir, any comments?
No, so what I was trying to tell you is that first of all, it is rare. And as Dr. Mandal correctly said, whatever we know, it has very little impact on the phenotype.
Correct.
So that is it. But yeah, the problem is that when the couple, especially one of the partners, gets this, they are under tremendous anxiety. So our job is to make it clear that this is not what we call as a typical thalassemia mutation. There is an abnormal mutant, but whatever we know, and even with in other interactions, it doesn't do much harm. So don't worry. Sometimes we have to alleviate the worries also of the people who have undergone the test.
True.
Absolutely.
Very true. So my next question would be to Dr. V.K. Khanna sir. So now this couple knows we didn't do a prenatal diagnosis. The child is compound heterozygous, or if I say double heterozygous actually, for HB Tigard and
No,
HB.
no, Dipanjana. It is never double heterozygous. Double heterozygous means two heterozygous mutation in two different genes.
Okay,
Like two
fine. This
different
is
mutations for
HBB gene.
definition. This is
Yes, this
absolutely
is
compound heterozygous
Compound.
because the
compound
same gene.
heterozygous. Yes. Okay. So this is compound heterozygous. And if we are looking at a compound heterozygous, so Dr. Khanna sir, what will you monitor? How will you go
I
ahead?
think it has been partly discussed, and as Dr. Mandal has said, that these are type of benign type of mutation. They're not very severe presentation they will have. So we have to just monitor them from the beginning and look for any appearance of spleen and pallor, and then go for the testing when required.
So my case 4 is basically, this is a case where I am like the gestation is 26 plus 3. And what we look at is that the previous child is healthy. And at 25 weeks ultrasound, we are getting polyhydramnios, a bit of pericardial effusion, cardiomegaly, mild ascites, and a placental thickening. The middle cerebral artery peak systolic velocity is about 2 MOM, which is suggestive of anemia, fetal anemia. So my question to Kanchan sir over here would be, sir, how would we proceed over here? What should we be looking at over here?
Looks like we are dealing with a case of non-immune hydrops fetalis due to alpha thalassemia. Now, obviously, the prognosis is poor, and the only way forward for the couple is, if they want to give it a try, would be intrauterine transfusion. That's what I would recommend to them.
Okay, so if we are looking for intrauterine transfusion, before that, I would ask Kaushik sir, would you go for any molecular testing, or you will just go for an IUT and do the molecular testing later?
Absolutely, we'll do a molecular testing. We'll test the parents. And we know that this we have already discussed alpha
Yes.
has four genes, and if two are deleted, then they are carriers. If three is deleted, it will be BART. If all are deleted, alpha thalassemia. And in such a situation where there is fetal hydrops, the prognosis is very, very poor. So I would rather offer a prenatal testing in the next baby. I don't know, even if we save this baby with intrauterine transfusion, whether we are going to save him for long, except that we do a bone marrow transplant.
So I'll go back to Kanchan sir. Sir, in case like this is obviously the choice of the patient, they want to say no, I want to continue the pregnancy, and the option, as you said, is IUT if they want to persist on. So if you could just describe IUT in these cases a bit, and then we can move on to the next question.
Well, intrauterine transfusions can be done from 20 weeks onwards if we are actually dealing with a case of fetal anemia. And the transfusion is done directly into the umbilical vein. as you said, the irradiated leukoreduced packed cells with very high hematocrit we would transfuse, and there is a way of calculating the volume, how much we need to transfuse. It is not necessarily done under any major anesthesia. If the patient is very apprehensive, you can give them local anesthesia. If you can find a good insertion point into the umbilical vein, then you may not have to even paralyze the baby. If you have difficult access, then you can paralyze the baby by giving some pancuranium into fetal thigh and then access the intrahepatic part of the umbilical vein. And this is not a very common procedure in our part. Luckily, maybe credit goes to our adherence to antenatal prophylaxis or postnatal prophylaxis of anti-D injection. But I understand where Dr. Kaushik Mondal practices. They have a lot of IUTs due to RH incompatibility. But for thalassemia circumstances, I haven't come across a case yet where I had to transfuse a fetus because of this purpose.
Because even the prognostically, it's not, I guess,
That's
great.
right. Yes.
But say in this case, the couple persists, they did an IUT and they delivered the baby. So I'll come back to Dr. VK Singh, sir. Sir, what would be the neonatal course in this case? Sir, are you there? Sir?
I think that's for Dr. Virendra Khanna, no? Or for Dr. VK Singh?
No, sir. It's for Dr. Khanna. I'm sorry. It wrote. I wrote wrong. Yeah. Yes. Yes, sir.
Yes. I've never come across such a situation actually. So I don't have that much experience of this, but definitely we'll have to transfuse him right from the beginning, and then we have to keep it because this is most likely going to be HBH disease, and we don't know the behavior later on. But since child had intrauterine anemia, is likely to be a transfusion dependent child later.
Right. And maybe the prognostically also it's not good. So we should
not going to
this
be very good because his
pregnancy.
child
Yes.
has already developed anemia so early in
Yes.
that.
So
Because we don't see this type in our part of the country.
No, it's very rare. It's absolutely very rare. So here we have another. It's sort of a trick question for the case 5. So we have a 32-year-old male software engineer. He has abnormal HPLC suggesting beta thalassemia trait. He's completely asymptomatic, but his initial workup shows that his HbA2 is elevated, and he has been reported as beta thalassemia trait. So my question over here, and they have, because they are trained, they have gone ahead, and as Kaushik sir has been sort of suggesting since the evening that a molecular testing should be done. They have done a molecular testing and it's normal. So now they also tested the parents, and the parents are also normal. So my question here would be to Pranta sir, that sir, what do you think this is like? How can we explain this?
Yeah, can you show me the indices once again?
Sure, sir.
So there is microcytosis. RBC count is high. A2 is elevated. But yeah, so there is some trick here. So then obviously what comes is what we were taught during our training is what are the other causes of elevated A2, right?
Yes.
So it might be drug, it might be certain other things. So we need to take a thorough history. I think that is very important. Okay, so you have got an HIV positive status, and so you have antiretroviral, and they can lead to increased A2. Okay, so that
Yes, the reason why I actually had put this, because we right now are screening a lot of individuals, and many of these individuals have not disclosed their HIV status,
yes.
thinking
And they are
that
on heart, so otherwise also
Ah.
they are not symptomatic.
yes,
Absolutely
they are
correct.
asymptomatic, and they and I actually have faced like two of these patients, and it actually baffled me until I went back and I asked them back, and they were not very clear because they did not want to disclose in front of their family that they are HIV positive. So I feel the status is something also that sometimes we should be discreet, yet these are certain things that we should also consider when looking at the report. So Pranta sir, if you can say that what are the factors that can falsely increase or decrease the HbA2 and influence the HPLC
Yeah,
reports?
there's a list of drugs which you can go through there, and sometimes I don't even remember the full list because I've not done it for quite some time. But there are certain conditions, metabolic as well as drug induced, where A2 can be falsely elevated. And the thing is, should I send it to Dr. Mondal or not? And then he would get angry, right? So obviously, what I say is, even when you are doing a screening, please take a good history, at least of what the drugs the patient is taking. So that is clear, and you look at the list, because otherwise it's a wastage of resources.
Resources.
Yes.
Right. So our last case, and we will be very quick because I have been asked to wrap up. So a couple has a child affected with thalassemia major. They now wish to have a healthy child, but they wish to have this HLA matched and free of disorder. So this is a question to Brigadier Sanjay Singh, sir. So what would be your suggestion in this case?
Ma'am, if I paraphrase your question and try to understand the requirement of the patient, I'll say that in this case, the couple is seeking to have another child who is both free of thalassemia major and HLA matched to their affected child, likely for the purpose of hematopoietic stem cell transplantation to cure the affected sibling. This I could understand. So there will be two answers to the requirement of the couple. The first and best answer to the problem is pre-implantation genetic diagnosis, wherein they need to conceive by IVF-PT and ICSI, and during blastocyst stage, one of the trophoectodermal cell is biopsied and tested for the disorder as well as HLA matching. Only embryos that are both unaffected for thalassemia and HLA compatible would be selected for implantation. But there is a big but. But as we know that PGD is available at very limited center of our country, so theoretically it appears to be very sound, but then it is expensive, not available, so it may not be feasible. So the second alternative is prenatal testing, where the lady is subjected either to amnio or CVS for the detection of the thal status and HLA matching. And based on the finding, the pregnancy may be continued or aborted. However, it cannot be guaranteed HLA matched or thal unaffected pregnancy in the index case. It also raises ethical and emotional concerns if termination is considered after unfavorable result.
Thank you, sir. So very quickly, Kaushik sir, what is the success rate of
So, so the biggest question is, we cannot terminate a baby if the baby is not
is a
HLA
carrier?
matched.
Yes.
Yeah, that's
No,
true.
not HLA matched, right? So we prenatal testing in this situation is probably not a good answer for HLA matching, right? So prenatal testing can only be done for the
Carrier.
thalassemia status of the baby. If the baby is homozygous or compound heterozygous, then there is option of medical termination of pregnancy. Medical termination of pregnancy cannot be offered if the baby is not HLA matched, but
Yeah, that's correct.
otherwise carrier. Yeah.
Can I
So
say a word?
yes.
Even, sir, in case of PGD also, I feel somebody will get up one day and they say that you are going for a tailor-made baby for the existing patient. So they may also object one day. So far, we are all doing it. It is allowed, but we don't know when it will be
So on the
banned.
fringes of
Yeah,
ethics.
Yes,
Wonderful stuff,
yes.
I think it is. Kaushik sir, if you can finish your comment, and then Pranta sir can say how
So
much
this
match
is
is.
permutation and combination only that both will be absent and whether there will be a match. So it's the permutation combination and Dr. Prantar will tell
How
about
much match is a match?
how much match
Yeah,
is a
yeah,
match.
yeah. So before that, I thought that I missed telling you that megaloblastic anemia also gives rise to hemoglobin
Yes.
A2 rise, also hemoglobin F rise. Any stress condition can have both, and sometimes in hypothyroidism and liver disease, but these are extremely rare to have that amount. There is something written in the literature which I found interesting, but I've never found it to be true in my professional life is when you give iron supplementation, sometimes A2 might shoot up. But I think these are all in the era because Biorat itself, variant 1 was validated on only 35 samples, right? So as you do more and more, you'll come to know. Coming to this for a sibling, match sibling donor, we say 6 by 6 is enough. If you want to do more, it's only for looking at high resolution matching. And if you want to do an intermediate, it's 10 by 10 match. So 6 by 6 is enough. But whether it is ethical or not is a more important question here. And I firmly believe that this should not be the way ahead.
True. It I guess it's still allowed in India, but we need to
Yeah.
take a call on this. Yes. So that's the reason why I put this question. So ethical boundaries, because of paucity of time, I will not discuss. But one last question with Dr. Kanchan sir, and we wrap up. Sir, even if we do a PGT, should we do amniocentesis? Like, what's the role of amniocentesis over here?
Yes, I think one message should be made loud and clear that PGT is basically a screening test, and we are testing the trophoblasts, and it should be seconded by amniocentesis, not the CVS. So that should be made very clear at the outset, and they should be prepared that they should undergo an amniocentesis later on.
Okay. So PGT is a screening test. There can be confined placental mosaicism. There can be a lot of other issues. Hence, an amniocentesis, not a CVS, is mandatory when we are looking at PGT. So with that, I thank all my panelists. I thank everyone for their time. And I thank SFM for actually giving me this opportunity to moderate this session. And I think it's open for questions.
Thank you, Dr. Dipanjana, and thank you to our wonderful panelists for this brilliant session. I would request Dr. Ashok Khurana to kindly take on the question session, please.
Thank you. And it's been a very exciting panel. It's a lot of rare situations, what we think are rare, except for those who get cornered with it and then they realize it's not so rare. And I wish I'd listened to that webinar. Thank God all these webinars are onto our YouTube channel and ready for access all times. We've had a lot of questions answered during the course of our conversations today. So I'll try and take up those that have not been answered so far. And there was a very interesting question right in the beginning, and this was from Dr. Sujata Swine. And she wanted to know the role of universal umbilical cord blood screening for hemoglobinopathy. So let's start with Dr. Kanchan Mukherjee. Would you ever suggest this to your patients? And what do you think are the possibilities of a universal screening?
I think universal screening is a must, basically. If we want to eradicate thalassemia, then it has to be universal. We cannot just pick and choose. And by screening, I am suggesting HPLC. And the best time window is when they're in their early pregnancy. We have tried and tested several other times, like spool age, like premarital, preconception, and unfortunately, all have failed. And we should go for prenatal screening.
This question was specifically for umbilical cord blood screening. At the time.
I think you mean neonatal screening.
Yes, which means that you have, we have in right there, we have the neonate and the newborn, and we screen cord blood for everybody. Is it practical? What are the options here? And I'd also ask for Dr. Khanna's input on this.
I think as far as neonatal screening is concerned, see, it is good for detecting. You may detect sicklers at this age, and there it is required to detect them early because they may have problems early also in during infancy. As far as thalassemia is concerned, even if you detect at that stage, what are you going to do? Because the child is already born with thalassemia and they don't present that early in 3 months or 2 months like that. So universal screening in the newborn period for that, I know it is there is some uh, program going on in Delhi also. There was a thesis which was submitted on neonatal screening for thalassemia, and it has been taken up as a project now in Delhi. But personally speaking, child is already born with thalassemia. Even if you detect, it's the prenatal doctor. Dr. Kanchan has said that prenatal screening universal is a must. I think they can't make it mandatory, but they should consider it strongly.
Dr. Ratnapuri, your experience on this?
Sorry, as Dr. Khanna said, for beta thalassemia, screening a newborn doesn't add to management because you're going to wait for symptoms. I'd rather everybody screen for hypothyroidism than screen for newborns. I think that is more relevant.
Absolutely right.
Sickle
And
cell, yes, because there is intervention.
Yeah.
Is it?
So we have to be careful that not everything applies to everything. So this is not something that we would even think of adding to our list.
and the
There was
technique
another,
is also different. It's isoelectric focusing rather than HPLC. HPLC can't detect.
of
Yes.
course,
HPLC and which yeah.
yes. And so it would just be something fashionable rather than something
Yeah.
scientific. Now, there is another very interesting question, which I think defeats the purpose of the whole webinar, but I think it's important to emphasize at the end of the whole story. And Dr. Jyotsna Pathak wants to know if only the mother has thalassemia trait, do we need to do prenatal testing? I think we brought this across many times during the course of the evening, but if one of us could please re-emphasize this, and let's have our moderator, Deepanjana, talk about this. Only the mother has thalassemia trait. Do we need prenatal testing? Husband's been tested and he's all clear.
We have repeated this a number of times. So we all know that thalassemia is an autosomal recessive disorder. So both the parents have to be a carrier for a child to be affected, which means if the mother is a carrier, we first test the partner. If the partner is not a carrier, there is no need of a prenatal testing. We don't want to test the fetus for no reason. If the partner is a carrier, depending on what kind of variant we are looking at, then only we go for a prenatal screening. The idea of prenatal screening should be only when it is something life threatening or something where there is a problem in the quality of life significantly. If there are variants which are milder, which we know, like we have spoken, like HPE homozygous, HPD homozygous, which we know do not cause too much of a problem, or they are absolutely asymptomatic, we don't need it. So the combination also matters. Number one, the both the partners have to be a carrier. Then only we can. It has to be proven molecularly. Then only we go for a prenatal screening.
Yes, and therefore the only situation that would ever arise is this very modern situation where the paternity is not known. So if the father is not known, such as in a semen donation, a sperm bank sample, or the mother herself is not sure who the father is, then we could possibly consider this. But if the paternity is assured, then we really don't need to do any such thing. Yes. The next question is from Dr. Razaul Karim, and he wants to know, should we go for prenatal if both parents are hemoglobin E trait? So, Prantar, your
Yeah,
opinion?
yeah. So we have discussed it. We know that the phenotype would be mild, so we do not do it. But I faced a tricky question here. The wife stayed in another place. The husband was posted in another town. And she said, if my child even needs 1 unit of transfusion, in the next 10 years, I am not willing to take the hassle. Then I said, see, it is clear that we do not intervene in the fetus unless it is necessary. But then she told, I am giving it in writing. And I then referred this case to Kanchanda. I do not know what happened, because there are some people who do not, still, because obviously I can't tell them that they will never require a transfusion. But most of the people are understanding, and we clearly tell them, and we use the same British Committee of Standards hematology pattern, which was there on my wall. See, this does not require. I think that is the clearest message we can give.
We had a beautiful discussion in our SFM Bengal WhatsApp group recently with the same question. Before that discussion, I was quite blasé about not doing prenatal diagnosis, but there, Dr. Kaushik Mondal taught us nicely that hemoglobin E can actually elute in the same way like HbA2 does, and it can be a wrong diagnosis. Kaushik, am I correct? Was that the right interpretation of what you said there? And from then on, what I am doing basically, I am basically offering them sequencing if they are all both are HBE and they can afford, and then genetically prove that they are genuinely HBE and we are not dealing with any other variants in their genetic studies.
But E carriers generally will have much high A2 level or the same window level. Uh, Unlike carriers which will be around 6, and for E carriers it will be above 20 or something.
25, 27, 28, yeah,
Yeah.
those are the range. But then I have got cases
But
like
it is
what
always
Pranta
good
said.
to be cautious. Yeah.
Yes, we have been cautious, and even I have been successful. I mean, maybe that conversation was happened about 6 months back, and in this period of time, I have found a case where HPLC reported HBE trait, and then we found something on the MLPS study, and we had to do a prenatal. So it was tricky.
Thank you. So the next question is, this is from Madhura Gadekar. What is the outcome of hemoglobin D Punjab homozygous? I know some of these are repeats, but let's hear the answers again. Anybody on the panel? Dr. Kaushik, would you like to take this?
Yeah, sure. So hemoglobin D Punjab is absolutely benign, and to the best of our knowledge, we should not intervene. We should not make them worried about what they are having.
And when does it become non-benign?
If there is another beta zero mutation, it might present like a intermedia. So we'll tell them. But if both are HBD Punjab and we have proven that it is C dot 364 in the third exon, we have proven it. So we keep quiet and ask them to keep quiet and
With
relax.
hemoglobin S, SD.
Yes, is also.
Is also
So that's the one that we encounter in Delhi all the time. And
There's one thing, when it's hemoglobin D Punjab will always have a normal CBC. I mean, unless there's iron deficiency, which would be different from a carrier. Sometimes, because hemoglobin D Punjab is common in northern India, they can carry a mutant allele in cis with hemoglobin D Punjab, and therefore it's very important to look at the complete blood count. So if that is suggestive of a microcytic hypochromic anemia, sometimes the A2 may not be high. It may be just borderline. It's important to exclude beta thal carrier.
thank you. And our next question is from Dipali Sable, who wants to know when to test for HPLC if your pregnant patient has severe anemia and has received a blood transfusion in the last month. So how would this influence the outcome of our testing? Who is going to take this
I
question?
think, yeah, I'll take it. So
Yeah.
our standard dictum is that if RBCs have a life of 120 days, so it is safe if you do it at 3 months. Sometimes it is not possible. And then we have a cheaper way of looking at it if the parents are alive, right? So if you have a problem in interpreting it because of the blood donation, and obviously the donor can be normal, the donor can also be a carrier. It has happened because we have a very high carrier rate in our state. So then we also look at the parents. If we can't come to it, again, we go to Dr. Mandal if we need a diagnosis.
And then there
Or
is
the
this,
husband.
Yeah,
yeah,
The
or the
husband.
husband. Yeah, definitely.
And
If the
especially
husband is
if it's
clear,
an
nothing to be done.
and especially if it's an IVF with the donor ovum, we need to check the husband. We forget
Yes.
all that
Yeah.
usually.
yes, paternity, maternity really needs to be sorted out very carefully.
Yes.
A lot of IVFs are now secret. Nobody gets to know that they've been done. A lot of donors are secret, and we start investigating when actually the poor embryo has nothing to do with the mother or the father. And then we realize that, oh my goodness, are we going to miss something here? And
We
so,
have some cases like that where
yes, sir.
the
Yeah.
donor egg was not tested and child has turned out to be E beta thalassemia, luckily not requiring regular transfusion.
Yes. But with the, there are cases in Delhi that keep cropping up with this sort of a
Yeah,
thing. And a lot of it is brushed under the carpet. So we must be very aware that
yeah.
there's a changing, fairly unethical medical scenario going on, where we have to have a very private conversation with the mother about paternity and maternity.
Yes.
And otherwise, we will have these increasingly common situations. And
With with thalassemia, sir, this maternity paternity thing is one very big thing that we actually encounter, and counseling becomes very difficult
yes,
because sometimes it's incest inside the family itself. And like Kaushik sir knows, sometimes I actually bug him too much that, why this has come and why this has not come. But this is something that even counseling becomes very difficult because the initial reaction is denial, and then we have something scientifically and we have to prove it against it. The other part I would also like to mention, that there are, though this is a bit uncommon right now, but I'll still mention it, that when we are doing a molecular testing in the fetus, please also go for the MCC, like the maternal contamination, because that is something we miss at times. Like normally we shouldn't, but that also sometimes gives us false positive reports. And though it's mandatory for most of the labs, but then it is something that we should also mention in the panel, that when you're testing the fetus, please get the MCC done and don't miss the MCC as well.
So no prenatal testing can be done without testing MCC. And if you have seen the QFPCR reports or the peaks, there can be very small contamination, but that can be picked up as a carrier in the molecular testing for thalassemia. So what we do, we run in parallel. We do a QFPCR, we see them, and when we see heterozygous peaks, I am very jittery and try find out whether it is the father's mutation, whether it is the mother's mutation. So if it's the father's mutation, I am happy. If it's the mother's mutation, I check several times the QFPCR peaks.
excellent. Thank you. There is
And
another,
it's an unwritten rule actually that whenever you're doing a prenatal and you're taking a fetal sample, you have to take the parent sample. It doesn't matter if obviously the mutations are known, but it
yeah.
kind of like validates the fetal test.
Yes,
And also
mother's
there is,
sample, we generally will always take the mother's
No,
sample.
I'm
So if
saying the
it's the
No,
couple
we take
also need
both
to
the
validate the variants. We take both.
both
Yeah,
parents.
yeah.
Yes, we take
Parents
both.
for molecular testing, but for QFPCR, we run the mother because it is a costly test and you see all the picture of the mother. That means it's the absolute maternal contamination. So there we generally don't take the father
Ashik,
sample. We
what
don't
I'm
run the
saying,
father sample.
you
Yeah.
already know. My question is about the mutation. You have to do MCC, but what I'm saying is in a prenatal sample, you're doing a prenatal with known mutations, but you still take the parent sample because when you're running your CVS, the DNA, we also run the parents alongside again just to validate. Prenatal is a big thing. It's not a casual thing.
Absolutely.
yes. So actually, it's a very good policy. And also, a lot of husbands would disappear to jobs in other cities, and then running after a sample becomes impossible. And that sample is bound to get spoiled in transport and things like that. So whenever we do a sample, it's really wise because they have to come and sign the papers anyway. to make sure that we have one father sample, one mother sample to make sure. There is another related question, again, to sort of give a state of completion to our discussions this evening. If HPLC shows THAL trait in both partners, should we go for trio analysis or first to molecular of parents and then prenatal? I think this comes from confusing ourselves over what is available these days to what we do in other conditions compared to what we do in a thalassemia. Dr. Ratnapuri, would you like to answer that question?
I'm actually trying to understand the question, so I was trying to find it in the chat box.
It's at 9:26 p.m.
Yeah, so
While
if HPLC shows THAL trait in both partners, should we go for trio or first we should do molecular? Okay, so the parents are carriers by HPLC. We identify the variant, the mutation in the beta globin gene in both partners. Once that is known, only then a fetal sample is taken. So a trio means 3 people. If there is an affected child, in my lab, the policy is we take the parents of the child. We do a family study for beta globin. We may not put it on the report, but it's there in the lab. Every lab has its own policy. It's how you work it out. Because once you're giving out a report, you need to be confident because so much action is going to be taken on that report. So,
actually, in fairness to the person who has asked the question, I think we in Kolkata run both the systems. Uh, back in
systems means?
basically we test the parents when they are coming from medical college or NRS medical college because they can only the fetus against the known common mutations, and they are using arms PCR where they are testing 6 common mutations. I mean, this is a method that when Kantar was in the government sector, that was started back in 2009 or 10, and it is still running. We do not have the facility of sequencing the samples. Therefore, we have to make sure that we can test that sample and then only we stick the needle in. If I am dealing with a couple in a private capacity, then I know that the lab I'm sending the sample to will be able to handle the entire situation no matter what happens. So,
Can I just answer that?
please.
I think there's one principle that we have to identify the mutation in the beta globin gene, either in the first affected child if there's one, or in both partners if there is no affected child or the affected child is no more. The mutation has to be identified. Once you put in a needle, you know, well, IVS11, IVS15, there are 2 mutations that you need to test. How you identify the mutation, like I said, is lab dependent. I also understand that you can't have the same facility in every laboratory.
Yeah.
If the mutation is identified by the ARMS PCR and they have made sure that the method that they are using in their lab is well validated, it's okay. If they have not identified it, well, then that has to go to another lab for sequencing before a needle is put in for CVS. Otherwise, how would you do the CVS?
Yeah, I understand. And a lot of the times, an abnormal HPLC becomes a normal HPLC on the repeat test because they can sometimes carry a piece of paper saying that was done at a health camp at a remote place. So, in large numbers,
Those
yeah,
are challenges of
So
quality.
these are the real life
Yeah,
challenges.
I agree,
what
100%.
what
These are
I
not
follow
real life challenges.
Sometimes
We had
also,
HPLC from Singapore, which are wrong. So they are not public
what
health challenges.
yeah.
Over to you.
What I follow in our lab or our department, if there is an affected child, we test the child, find both the mutations or the homozygous state, and straight away do a prenatal, right? I do not take the father's sample. I take the mother's sample for QFPCR to rule out maternal contamination for two reasons. One, that paternity is something which is very tricky. And I assume that the first child father will be the second child's father, and it's onus of the parents or the couple to have a second baby. So I'll write that the proband's mutation is this, or the affected child's mutation is this, and the fetus is carrying both mutation or none of the mutation or one mutation. Fetus will be carrier and status of the fetus, just like that. And I always write it's the targeted mutation what I have found in the affected child. When the affected child is not there, and the child died of thalassemia, then I test the parents, or the parents are found incidentally to be carrier. I do the mutation testing and do a prenatal. The second one, why I don't take the father sample is that they come with chacha, papa, and all of them they call is baba. And if you take the sample, you find something else and you do a prenatal. So I generally will not take the father sample if the proband is available and we have identified both the mutations, because we end up in lot of uncertainties
Can
in
I
that
ask
situation.
one question over here? Like it's something that I guess it was asked, but just for the for the panel, for the discussion. So many a times we get cases, especially like this everyone faces in India, which are very late. We get cases at 24 weeks. In these cases, what would you do? Would you first sequence
Yes,
the
yes.
parents
I,
and
no, no,
then
no,
will you
no, no,
sequence
no,
the
no. They come from Bihar. They are coming from Bihar. They will do.
both?
So in
Yeah, yeah.
that case, both are clearly carriers. I take both the couple sample or prenatal, taking it from their writing that sometimes we might miss a mutation, we might not get a mutation. There can be wrong reports, and prenatal testing is risky. But I do it together. Yes, if they
Because
come
many
at
a
around
times we
very late.
see, but especially when I counsel in the rural areas, I get patients who are referred at 24 weeks, 26 weeks, 28 weeks. So and we really don't have time for these, though it doesn't take too much time for actually sequencing and giving the reports, but we do get them very late. But
We
with
also
the
do
recent
it simultaneously, but
yes,
it's important to make sure that the HPLC hemoglobin A2 with the
yes,
CBC report is correct. That's all.
yes. So, ma'am, here I would
I
actually
generally do a in-house test. In all, I will repeat a in-house test.
no,
Then
here
I'm
I need to re-emphasize this because right now it seems that every corner of the city has a HPLC lab and they are furnishing a report. So how would you actually, if you're seeing a report and you feel suspicious, how many times would you actually repeat an HPLC? Will you
I do
actually
it in
repeat
my
or
hospital because you're going to put in a needle and you need to do a prenatal diagnosis. It's all right to spend a little more money and be confident in what you're doing.
yeah. So
absolutely.
and always have a CBC because some people always just come with an HPLC. They don't have a
We do a
CBC or the other.
Absolutely.
CBC.
Yes.
So then
Absolutely.
we do a CBC.
Yeah.
It
So
can't go to the lab without that.
Yeah.
So
so that was an important point to
Yeah.
emphasize because many a times people come with an HPLC and we say please do a CBC and come back and then we will do further whatever needs to be done. Yes.
we have taught our residents, you write the CBC in the center, you write father, you write mother, you write the values so that it gets ingrained in their heads that that's how you have to read it.
Absolutely.
Yes. And then there is this final question, which, well, no, we have two more, but this question, which we need to clarify, what is the difference between double heterozygous and compound heterozygous?
And that was my
I
So,
mentioned this.
so
Yeah.
let me answer this. So compound heterozygous means two different mutations in the two different alleles of the same gene. Double heterozygous means two heterozygous mutations, so in two different genes. And if it is the same gene in the same allele, it is called the mutations are in cis, right? So it is even not double. Double heterozygous means two heterozygous mutation in two different genes, like two deafness genes, two
GJB2
different
and
deafness genes,
Yeah.
two different heterozygous mutations, that is double heterozygous. So there is no confusion about double heterozygous and compound heterozygous.
Yes.
Compound heterozygous means same gene.
And therefore, the clinical implication is
Clinical implication is if it is compound heterozygous in autosomal recessive condition, the person will be affected. In a double heterozygous, it is slightly tricky. One might be modifying the other. So it is something which is need to be studied.
There are
and
some genes, like the deafness gene, where you can
title.
a mutation in two different genes and it behaves like an autosomal recessive. So you just have to know these things. But for thalassemia, there's no double heterozygous, at
Yes.
least what I know, unless they are modifiers, but not causing disease.
Yes,
Yes.
like gamma globin gene and beta globin gene, two different
Or
mutations. So it
alpha,
can
beta,
be,
alpha
yeah,
Alpha,
triplication.
beta.
Yes, yeah.
absolutely.
And therefore, the importance of post-test counseling, which seems to have been completely forgotten, where the clinician receives a report and it looks okay to them, and something gets missed. I think it's very necessary to set a trend that we need post-test genetic counseling, which is as important as the prenatal counseling. And we must give every genetic opinion that kind of respect. So every clinician should be aware that if there's anything that looks out of place, or you feel you're not really experienced enough in the subject, we must refer them for a post-test genetic counseling. Which brings us to the next question. This was related to the pre-implantation genetic diagnosis. Uh, for major, do we do genetic testing for major aneuploidies as well? Or then during the pregnancy, do we do NIPT or prenatal testing? So we've had a prenatal genetic diagnosis done. We've chosen the right embryo. Then the embryo has been implanted. We've reached that stage of 12 weeks, and we're now carrying out assessment of this pregnancy. So do we need to then test for aneuploidies as well?
Sir, can I answer this?
Yes.
Yeah. So normally, when we do a PGT-M, like when we are testing for them, we also offer for aneuploidy screening, because it's almost in the same, because we would like to actually transfer a euploid embryo. So when we do a PGTM, in most of the cases, we do target it with a PGTA, but we also have to remember that these are trophoblast biopsies. So when we are implanting them and they have gone through the pregnancy, we cannot do another screening test. So NIPT will again look into the trophoblast cells. They are again looking into the placental cells. So we will not be using NIPT for any aneuploidy screening. Plus, we need to understand that NIPT will only pick up numerical aberrations as far as what we are doing right now. So we have to offer an amniocentesis, which is actually looking at the fetal cells directly. And it's a rule that when we do a PGT, because PGT is also a screening test, we have to do a amniocentesis around 16 weeks, and the patient has to be counseled before even you start doing a PGT, and it's mandatory that is done. Though the concordance is about 99%, but still this has to be offered and this has to be done. And there's no place for NIPT when we are doing this.
Yes, and also we must let them know that look, when we are doing these processes, it's wiser to actually do amniotic fluid and not a CVS, because that would be too representative of fetal cells. And and then for the aneuploidy section, some of them would be accepting to have a baby with Down syndrome, which is okay. That is their personal choice. Otherwise, they must have an assessment for Down syndrome as well. And then there is a question on whether cord blood storage is useful in the future in case of hemoglobinopathy.
Yeah, I think I'll take this
Yes.
because I love taking it, countering Aishwarya Rai and others. So first of all, private cord blood banking is illegal, according to American College of Gynecologists. And why would you keep a cord blood, right? If you think that you are planning a transplant, the baby will be with you. You collect stem cells whenever you want and do it. And if you think that obviously for a hemoglobinopathy, you're not going to use that for other reasons. So there is, again, as Dr. Kurana was saying, so many unethical things going on. And, we have written emails, letters, and all those things, but there are EMI schemes and everything. So let us make it very clear. If you're thinking of transplanting your child with sibling stem cells, the sibling is there for you. Cord blood might not have adequate stem cells. So please wait and then look at a match, even if you can do, if there's a half match, you can do a haploidentical, but why do you need cord blood for that?
True. That is thank you for that very nice, beautiful message. And then our last question for the for tonight is this is from Dr. Gyan Yamini. Sir, have you ever worked in south of India in Karnataka and Andhra? Because she's come across many thalassemia cases in both the states. And what are the major polymorphisms and mutations that you have come across?
I have never.
Has anybody worked?
I worked in Tamil Nadu, but I rarely found
Since
thalassemia
birth
there.
in Delhi only.
Yeah.
Yes, yeah. I mean, in Delhi, we just come across this like so routine. Wonderful.
And I'm in Tamil Nadu. I haven't faced a thalassemia patient till now, but I live in a village, so they might not be there. But obviously, when you talk of Karnataka, we have these pockets of sickle. And
Yes.
sometimes, rarely, we get sickle beta, but they are mainly in the migratory population.
Yes. And you know, this is something we have to be aware of, that sickle cell is going to turn up in the great world of information technology, the IT group, because they keep moving from city to city. And with the new stuff coming up in Gujarat, the locals are all sickle cell high risk, sort of a high prevalence. So we have to be very careful on who goes and works in which city, because if you have one isolated person from Karnataka going on to Gujarat and settling down there and having a Gujarati wife, then their risks change completely. And so we have to be really careful of this migratory IT population. Luckily, they're protected by insurance and a lot of other expenses. So we should investigate them on a routine basis, especially for sickling. Because that sickling has now become a major problem only because of migrations, not really because of anything else. Yes. Well, thank you very much to panel for making this so exciting. And I know this will form a very important part of our repository on our YouTube channel. And it's been a pleasure handling these questions. So back to Colonel Rima for closing the session.
I really thank first the delegates to be here so late, and of course Dr. Khurana to lead us, to guide us, to have these wonderful panels, to Dr. Ratnapuri for this wonderful lecture, Dr. Dipanjana, and our wonderful panelists for the wonderful panel. Thank you so much for being with us today. I thank you on behalf of Society of Fetal Medicine. Thank you.
Night. Good
Thank
night.
you. Good night.
Good night. Good night.